On-screen text. Webinar and Dialogue with Experts Series. Fetal Alcohol Spectrum Disorders, Bending the Trajectory. June 13, 2023. Noon to 1 p.m. Open brace PDT close brace. 3 o'clock to 4 p.m. Open brace EDT close brace. National Center on Substance Abuse and Child Welfare.
Good afternoon, everyone, and welcome to part 1 of our Dialogue with Experts series, Fetal Alcohol Spectrum Disorders, Bending the Trajectory. Thanks again for joining us, as we are delighted to have you here.
Acknowledgement. This presentation is supported by contract number 75S20422C00001 from the Children's Bureau Open Brace CB Close Brace, Administration for Children and Families Open Brace ACF Close Brace, co-funded by the Substance Abuse and Mental Health Services Administration Open Brace SAMHS A Close Brace. The views, opinions, and content of this presentation are those of the presenters and do not necessarily reflect the views, opinions, or policies of ACF, SAMHSA or the U.S. Department of Health and Human Services Open Brace HHS Close Brace. Logos, ACF Children's Bureau. SAMHSA. https://ncsacw.acf.hhs.governor/ncsacw@cffutures.org.
The National Center on Substance Abuse and Child Welfare is a collaboration at the federal level between the Administration for Children and Families and the Substance Abuse and Mental Health Services Administration. The National Center has operated since 2002 and provides information, consultation, training, and technical assistance to child welfare, substance use disorder treatment, court personnel, and other systems serving families. So let's get started.
Bending the Trajectory. The Developmental Challenges of Children with Fetal Alcohol Spectrum Disorder Open Brace FASD Close Brace. National Center on Substance Abuse and Child Welfare. June 13, 2023. Douglas Waite, MD, FAAP.
I would like to introduce our speaker today, Dr. Douglas Waite. He is the Division Chief of Developmental Pediatrics at Bronx Care Health System and the Assistant Professor of Pediatrics at Mount Sinai School of Medicine. I will now pass it over to you, Dr. Waite, to move us forward.
Thanks, Natasha. And I want to thank the National Center for having me to speak about this. It's something, FASD is something I came into really out of necessity, working with kids in the child welfare system, not having been taught during medical school or residency. So it was really recognizing the ignorance of myself that I began to learn about this, and I hope to share some of what I've learned with you. So I want to start with giving a brief summation of how we began to understand the effects of prenatal alcohol exposure on development prior to birth and what the kinds of developmental trajectories we see with kids with prenatal alcohol exposure.
Objectives. Describe the history of our understanding prenatal exposure to alcohol on neurodevelopment. Trace the brain-based developmental and behavioral manifestations of prenatal alcohol-related brain injury across childhood and adolescence. Highlight the synergistic effects of traumatic experience upon children with FASD, barriers to diagnosis and how these have shaped hesitancy to diagnose children and adults with FASD. Discuss interventions across the lifespan.
I want to talk about how those present in day-to-day life for both parents and for pediatricians that see children. And I want to talk then about, because we're focusing on child welfare, the overlap and the synergistic effect of kids who experience trauma as well as having had prenatal alcohol exposure. Then I want to get into the barriers of diagnosis and how really the barriers have shaped the inability to know for sure how many kids have fetal alcohol spectrum disorder. And finally, probably the most important part is discuss interventions and how we can begin addressing the challenges that kids and their families struggle with when kids have fetal alcohol spectrum disorder. Next slide.
A constellation of adversity. Recent child welfare statistics highlight the overlap of children who have experienced child abuse and neglect while also being at risk for prenatal exposure to alcohol and other substances. Of child victims of maltreatment in 2021, 76% of allegations were associated with neglect, 28.2% with domestic violence, 26.1% with parental substance use, 15% with parental alcohol use, 16% with physical abuse, 10.1% with child sexual abuse. 18% of child victims were under the age of 1 year and 27.8% were under the age of 2 years. Source: U.S. Department of Health and Human Services, 2023, AFCARS 29, Preliminary Estimates for the Fiscal Year 2021, Wilkson et al., 2011, Richards et al., 2020, Mainhofter and Diz, 2019. Close brace.
Great. So I think the best way to approach this is beginning to see the scope of adversity that we see among children in foster care. And this is looking at child victims of maltreatment. So not necessarily in foster care, but kids who come to the attention of authorities because of allegations of abuse or neglect. And you can see that neglect is the most common cause, the most common reason for referral to child protection. 76% associated with neglect, 28% with domestic violence. But you see right under that, parental substance use and alcohol use are really high up there in terms of the risk factors for kids who are referred to child protection. The other things that we commonly think of that are more something that we see or that shock us more, like child sexual abuse, or that we see on physical exam with physical abuse, are less common than the things that we don't see. They're the things that kids come into us with histories of neglect that affects development. And our focus now is going to be how those overlap with prenatal substance and alcohol exposure. Throughout this talk, I'm going to be kind of using these together because the comorbid use of substances and alcohol is high enough that I think we really need to begin to talk about them together. We'll talk about some of the subtleties of this as we move forward. And then the other part of this that is important to note is that a large number of the kids that come in that get reported to child welfare are young kids, kids under the age of 1, 28% under the age of 2. Next slide.
Of children entering foster care in 2021, 21% were under the age of 1 year, with neglect associated with child removal in 63% of cases, prenatal substance use in 36% of cases, parental alcohol use in 65% of cases, and physical abuse in 12% of cases. Children who enter care as infants are more likely to spend more of their childhood in foster care than older children, and 61% have reported active alcohol and/or drug abuse by the primary caregiver, the secondary caregiver, or both. While neglect is the primary reason for child welfare referral and placement, parental alcohol and/or substance use as a cause of neglect is often not captured in intake to child welfare services. In a study reviewing trends in foster care entry because of parental drug use between 2000 and 2017, children entering foster care because of parental drug use were more likely to be 5 years or younger. Open brace 39.65% close brace compared to children entering care for other reasons. Source: U.S. Department of Health and Human Services, 2023, AFCARS 29, Preliminary Estimates for the Fiscal Year 2021, Wilkson et al., 2011, Richards et al., 2020, Mainhofter and Diz, 2019. Close brace.
So when we begin to talk about foster care, you can see that this becomes even more striking and more highlighted with the challenges that we were just talking about. Not only are kids coming in at very young ages, 21% under age 1, and associated with neglect in 63% of the cases of time, but 36% associated with substance use and 65% of alcohol use, parental alcohol use. So this is a major challenge for kids, especially young kids entering foster care. And if we step back and begin to look at foster care as an opportunity, as tragic as it is to have your child taken away from you, it's an opportunity for us to begin to put interventions in place. One of those interventions can be diagnosing children, not only who have developmental delays, but who have disabilities because of prenatal alcohol and or substance exposure. We also know that children who come in as infants are more likely to be in foster care for longer periods of time. We know that kids who have FASD are more likely to have multiple foster home placements. So this group of kids are kids that are at the early stages of brain development where interventions can have a large impact. And one of the challenges that I hope you take away from this topic is how can we begin to identify children as they come into the child welfare system to get them supports to optimize the chance for reunification when that's appropriate. And finally, if you look down at the last slide, you see that, again, highlighting that kids under age 5 in this slide, 40%. So you begin to get an idea of how common the kids that are underage entering foster care are. Next slide, please.
Black and white photo of a baby. FASD, 1973. Facial features. Growth impairment. Neurodevelopmental challenges. Does not require documented fetal alcohol exposure. Source, Jones and Smith, 1973.
So that's the scope of what we're talking about. We're talking about kids with high risk for prenatal substance and alcohol exposure, kids with histories of neglect, which we know affects brain development, and child abuse as well. But when we begin to talk about fetal alcohol syndrome and fetal alcohol spectrum disorders, we have to go back to 1973 when Ken Jones and David Smith published a paper that first described fetal alcohol syndrome. Now, a syndrome is a constellation of features that doctors find on exam. Down syndrome was described by Dr. Down way before we knew that it came because of 3 chromosomes on chromosome 21. In this case, Jones and Smith postulated the name fetal alcohol syndrome because in all the cases that they looked at, the children that had facial features, poor growth, and then subsequent neurodevelopmental challenges, all those kids had documented history of maternal alcohol use during pregnancy. So they implied a causality here that alcohol is causing these effects that we found on exam. And since that time, in the 50 years since that time, we've learned that the majority of kids do not meet criteria for FASD. This is important because as we talk about the face, I want you to begin to forget about the face. Next slide.
Photo of an iceberg. FASD occurs in about 1 in 1,000 children. Open brace facial features, growth deficits, and neurocognitive disabilities. Close brace. The greater continuum of FASDs occur in at least 1 in 100 children. More recent estimates are 2 to 5% in the U.S. general population.
Because the greater portion of the kids that have an FASD are the kids that we don't see findings on exam. So the proverbial tip of the iceberg, that's 1 in 10 kids. The greater number of kids that have an FASD that don't necessarily have findings on exam are the 9 in 10 kids under the iceberg. And recent estimates document 2 to 5% in the general population. So as high as 1 in 20 kids in the general population. This was a group of first graders in 4 Midwestern states. So many people describe FASD as a hidden disability. This is one of the reasons that it's a hidden disability. Kids with FAS, where you see things, are more likely to be diagnosed. Kids that you don't see those findings are often to slip under the radar of diagnosticians. Next slide.
Alcohol consumption and binge drinking. Pregnancy among adults. Ages 18 to 49 years. United States, 2018 to 2020. 13.5% of pregnant adults reported current drinking. 5.2% of pregnant adults reported binge drinking. Both measures were 2 percentage points higher than during 2015 to 2017. Pregnant adults with frequent mental distress were 2.3 and 3.4 times as likely to report current and binge drinking, respectively, compared with those without frequent mental distress. Sources: Gostin, et al., 2022, Meisler, et al., 2014, Maynor et al., 2021, Parker, et al., 2010, Arneson et al., 2009, May et al., 2014, Centers for Disease Control and Prevention, 2022.
Those figures of 2 to 5% in the general population correlate well with studies that have been done by the CDC that looked into alcohol use by pregnant women. And you can see here that 13.5% of pregnant adults reported drinking in the past month during pregnancy. More alarming, 5.2% reported binge drinking, and binge drinking is 4 drinks at a sitting for a woman. And so that 5% of binge drinking correlates well with the upper limit of the 5% of FASD. And we know binge drinking is especially harmful to the developing brain. This also is something that has gotten more common. We've talked about drug use getting more common during the opioid epidemic, but in this case, also alcohol use has gone up during the pandemic. It's more common among women who have psychiatric illness or mental distress, like living in a home with domestic violence or in poverty. And it's also more likely to concur with binge drinking. Next slide.
Something's wrong with my child. On the left, 4 scans labeled A, B, C, D. Comparison of the face open brace A close brace and interior brain open brace B close brace of a normal mouse embryo and 1 damaged by alcohol open brace C and D close brace. The nostrils are abnormally positioned open brace C close brace. The brain is missing midline structures open brace D close brace. Image shows a mouse embryo with facial features pointed out including eye, nostrils, and mouth. Image C is similar except the nostrils and mouth are pushed up. Image B shows a brain with a midline structure that divides the space on either side into 2 round segments. Image D shows a similar brain, but the midline segment is shorter and the space is more heart-shaped. Source: FAS Diagnostic and Prevention Network Open Brace N. D. Close brace.
So when we talk about the facial features, the slide on the right is showing a child that has fetal alcohol syndrome. With the 3 sentinel or cardinal features of fetal alcohol syndrome being narrow palpebral fissures, the narrowness between that point A and B on that child, that gives the eye a more round shape that's exaggerated by these crescents of skin on the inner part of the eye that we call epicanthal folds. You'll also see that the face, the midline face itself, is flattened. It's like someone took their hand and pushed it into the developing clay of the face to give a flat nose at the upper part between the eyes, and pushing up there, lifts the nostrils up. So we talk about it, uplifted nose. And most importantly, the flat philtrum, the little ridge between the nose and upper lip that you see in this child is totally flat. And then a thin upper lip. So those are the facial features of FAS, fetal alcohol syndrome. But as I mentioned, this is 1 in 10 kids. If we look underneath the face and remember that the brain is the first thing to develop, and that the face develops, the brain is the first thing to develop, and the face develops around the developing brain. When we look at the brain features of prenatal alcohol exposure, you'll see in slides B and D on the lower part of the left, the little roof hanging down from the top of the brain that's called the corpus callosum is often small or absent, like in slide D, among children with prenatal alcohol exposure. And this is highlighting the midline brain, which is a very important part of the brain because the frontal cortex, the part of our brain that really distinguishes us from many of the other mammals, that's a seat of insight, judgment, executive control, regulating emotions, is often affected by prenatal alcohol exposure, as well as other parts in the midline brain, like the fight or flight response, again, emotional regulations, parts of the brain, and the back of the brain called the cerebellum that helps us with spatial awareness. So the brain develops first and the face folds around it. So abnormalities in the midline brain are often mirrored in the face. That's the general concept I want to get across. Next. Oh, and last thing, no one brings their kid to see you because their child has a funny looking face. I'm a developmental behavioral pediatrician, and kids parents bring their child to me because their kid is having marked difficulties in school, behavioral challenges at home, they're speaking late or not speaking at all. And this is why people seek help for their child. So they're not going to come see you because of the face. So I talked about the face, but now let's get into what happens with the brain, because really what we're talking about is abnormal brain development that causes behavioral challenges and developmental challenges moving forward. Next slide.
Alcohol kills cells in the developing brain. Two side-by-side images. On the left, a 10-day mouse embryo corresponding to a 28-day human embryo. The scan shows a dark line up the center and tissue surrounding. On the right, cells killed by alcohol have taken up dark blue stain. The blue stain creates almost the full shape of the image on the left.
This slide graphically, dramatically shows cells killed by alcohol in the developing brain. The brain is the first thing to develop after fertilization. And it's all a midline process, meaning it starts as a little tube that eventually folds into the top part of the brain that you see bending down there. That's going to be the major part of the brain, the rest of it being the spinal cord. All of those cells that are blue have been killed by alcohol. So if we talk about brain development as being a process of one cell becoming two becoming four, and then exponential growth, from there, you can begin to imagine how knocking out those cells affect brain development. Alcohol also affects how brain cells migrate to where they're going to be, how they link up with other brain cells, and then also myelination. That's a process where brain function is, the transmission is sped up. Next slide.
The most common cause of intellectual disability and birth defects in the United States. A bar graph of neurodevelopmental disorders. Prevalence per 1,000. The bars from largest to smallest are ADHD, attention deficit hyperactivity disorder, GDD/ID, global developmental delay, intellectual disability, FASD, fetal alcohol spectrum disorders, ASD, autism spectrum disorder, FAS, fetal alcohol syndrome, cerebral palsy, trisomy 21. Source, Waite and Burt, 2023.
So we now know that FASDs, fetal alcohol spectrum disorders, are the most common cause of intellectual disability birth defects. More common than autism, trisomy 21, or Down syndrome, cerebral palsy combined. And as we go through this, I want you to think about would any other disorder that affects children to the extent of 1 in 20 kids go so neglected by our society? And that immediately beckons the question of why. And hopefully as we go through this, I'll try to answer some of those questions. But I want to highlight that this is something that we're not picking up. And that is why I think I'm so appreciative for everybody for joining this call. So you can see on the far left here, global developmental delay, kids who have delays across multiple domains of development under age 5, often having a high risk for going on and having intellectual disability, what used to be called mental retardation. There's autism spectrum disorder, which is ASD, and then FAS, which you see as a smaller bar, and then FASD, which is the greater bar. The different colors represent the lower estimate to the full estimate being 2 to 5%. And then ADHD that towers over them all. And one thing to think about when you look at those ADHD numbers is, one, I can bet most of the kids that are diagnosed with ADHD, no one ever got a history of or tried to get a history of prenatal alcohol exposure. And two, most kids with FASDs get diagnosed with ADHD from a very early age, as early as age 3 to 5. So a lot of that pillar that you're seeing there, I think, are undiagnosed kids with FASD. Next slide.
FASD is especially prevalent among children in foster care. Source, Astley, 2010.
All right, so then when we talk about foster care, which is, kind of what we want to focus on, I want you to also remember that we're focusing on foster care, but this is not a disorder that's in foster care alone. And this is, we could talk about white, college-educated women are more likely to drink during pregnancy than a lot of the kids that enter foster care, where we know there's extreme racial bias. So I don't want you to think about this as being a disorder of foster care necessarily. I certainly don't want you to think about this having any overtones of racial prejudice with it, because one of the reasons kids are not being diagnosed is because of the stigma associated with the name fetal alcohol spectrum disorders. So I'm going to focus on foster care, but I want you to keep in mind 2 to 5% in the general population. Having said that, as we saw in the first couple of slides, the kids entering foster care are at exceptional risk for substance exposure before birth, as well as abuse and neglect. So of the first 1,400 children who were diagnosed at the University of Washington FASD Diagnostic Center with an FASD, 70% were no longer living with their birth parents. They were also had on average 3 out-of-home placements. And this is what I was seeing when I was working in a foster care, especially in residential treatment, kids who bounced around to multiple foster homes because no one could take care of them. Very, very difficult children to care for. Good kids who have a lot of developmental behavioral challenges. At least 34% were physically abused, 24% sexually abused, 75% had 1 or more documented psych illnesses, most prevalent being ADHD. That number, 54%, is probably an underestimate in my view. 93% had other exposures. So this is why I'm saying that we should begin talking about, with the talk of opioid epidemic and any other drugs that come through, like methamphetamine, we should be talking about alcohol and the importance of screening for alcohol, in addition to the substances that are already screened for in urine toxicologies at birth. And 1/3 had no documented history of prenatal care. Next slide.
And yet these children are not being diagnosed. Mental health diagnosis, learning and communication disorders, intellectual disability and objective signs of neurocognitive damage were not recognized in a significant number of children with FASD. Objective signs of neurocognitive damage were not recognized in a significant number of children with FASD. Source, Chasnoff et al., 2015.
And yet in a study that Ira Chasnoff and his team did in Chicago of children from foster care who were referred to his evaluation site who were diagnosed with FASD, 80% of those kids that they diagnosed with an FASD had never been diagnosed. And most likely, this is not in the article, but I would bet most of those kids no one ever even asked about prenatal alcohol exposure. The reason for looking into and making this diagnosis is because this is an underlying static encephalopathy. That means it's brain damage, brain injury that happens before birth that plays out over the course of development and affects neurodevelopment moving forward after birth. So we want to document this and recognize these challenges to advocate for services and help families and other caretakers manage the challenges moving forward and anticipate challenges down the road. So as we go through talking about FASD and the signs that we see and the challenges that kids with FASD have, I want you to think about one of the reasons children with FASDs are not diagnosed, and another reason this is called a hidden disability, is because on paper, so many of them look like they should be able to do this stuff, do the developmental challenges that they're apparently not able to do. Next slide.
Normal development. Markers from birth to age 3 years. Temperament, sleep, and ability to be soothed. Open brace. Emotional regulation. Close brace. Social interaction, eye contact, reactive smile. Motor, walking by age 12 to 18 months. Speech/language. Parallel play, 2-word phrases, sustained, symbolic play. Interactive play, 3-word phrases, symbolic play, goal-directed behavior, self-regulation. Source, Waite and Bird, 2023.
So this is showing the trajectory of normal development. And, you know, there's a wide range of what we call normal. And one of the reasons I'm putting this up is I want to kind of give you an idea of how early we begin to see differences in kids who have prenatal alcohol exposure and whether they've been diagnosed with an FASD or not. Early signs before the age of 3, even before the age of 1, just like we've begun picking up kids with autism before age 3, whereas before the age was like 5 to 8. Now we're picking them up before age 3 and getting them in early intervention. Same thing for this. And again, foster care is an opportunity to pick these kids up and integrate care. So from very early on, we talk about temperament, sleep, the ability to be soothed. That starts with being emotional regulation. So emotional regulation, when a baby cries, it's the response that adults have that comes naturally to try to soothe them and make them calm down. But it plays into also in temperament, the intensity and the difficult temperaments that many children are born with, myself being one of those, that have intense temperaments. And over the course of time, one of our jobs is to teach them how to manage that intense temperament and manage frustration as they move forward. But again, this is something that we see very early on. Many kids, I hesitate to say most kids with an FASD, have difficulties with sleep. I'm talking about kids who you try to get them to bed at 9 o'clock and they don't go to sleep till 2 or 3 in the morning. Very common with autism too. We talk about social interaction. At 3 months, when you're feeding a child, they should be looking at you in the eyes. When you go down and talk to them and say, goo, 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 they should smile back at you, right? That reactive social interaction that's often absent in autism. Motor, walking by age 12 months, 18 months at the outer limit, often delayed in kids with FASD. But the most common thing is speech language delays. So I think when you begin to look at speech language delays, this is one of the most common reasons that I see kids as a developmental pediatrician. And any kid with a speech language impairment should be evaluated by being screened for prenatal alcohol exposure. We're going to talk about that shortly. We talk about parallel play, playing next to each other, beginning to use 2-word phrases by age 2, having sustained play, sitting with the toy and playing for 5 minutes instead of running all over the place from toy to toy to toy and not engaging. Symbolic play, using a car like it's a car that you see on the street, vroom, vroom. That's symbolic play. And then the last part at age 3, we like to see interactive play, that back and forth. That's the beginning of what by 5 years will be conversation, where you're going back and forth. No, let's do this. And there's that give and take that we begin to see. That's often very difficult for kids with FASD, as it is with autism and kids with global developmental delay. So prior to age 3, these are very undifferentiated challenges. Many kids with FASDs are diagnosed with autism. Many kids with FASDs present as global developmental delay, all right? So the thing that's going to discern this and weed these kids out so that we can pick them up and identify the differences, we're going to talk about, but a lot of this is going to be the history of prenatal alcohol exposure, in addition to subtleties in these things we just talked about that are different from autism. Next slide.
Markers from birth to age 3 years. Intense temperament, poor sleep, difficult to soothe, open brace dysregulation, close brace. Social interaction, unsustained or absent eye contact, inconsistent or absent reactive smile. Gross and fine motor delays. Speech delay. Absence of interest in other children, poor eye contact, lack of sustained play, speech delay, hyperactivity, poor sleep, tantrums. Lack of interactive play, hyperactivity, aggressive behavior, tantrums, poor sleep, difficulty with transitions. Source, Waite and Bird, 2023.
All right, so these are showing the course of the neurodevelopmental disorders. And again, under neurodevelopmental disorders, it's a huge bracket. Autism, global developmental delay, intellectual disability, ADHD, speech delays, speech impairments, and FASDs. In the new DSM-5, which is not so new anymore, has a category for further study called neurodevelopmental disorder associated with prenatal alcohol exposure. That's probably a great gateway for pediatricians and frontline persons, psychologists, social workers, to begin to suspect this, just like they might begin to suspect autism. You don't have to make a diagnosis necessarily, but you could put it on the table and begin trying to get a history of prenatal exposure, or more importantly, begin getting interventions for the delays that you're seeing. So we talked about intense temperament, difficulty to be soothed. Those are like the colicky babies that we talk about. Difficult to be soothed because they have this emotional dysregulation that we're going to see moving forward carries throughout childhood and adolescence and adulthood. Social interactions. Now, unlike kids with autism, most kids with FASD do make eye contact. They do have responsive smile, right? Some of them don't, but a lot of kids are, if anything, socially gregarious. They're very interactive. And that's one of the differences we see with FASD and autism. They can have gross motor delays. I have some kids that didn't walk till they were 3. But again, a lot of times they might need help with occupational therapy for fine motor, but speech delay is the main thing. And one of the things to keep in mind with speech is that kids with FASDs, once they get their speech, they'll begin yakking away. And they'll be talking like a kid their age. But you have to repeat things because they're not taking in what you're telling them. That receptive language is far more impaired than their expressive language. So you think they're talking up here, they should be able to take in up there, but they're taking in far lower to lower age level. And so that looks like they're not paying attention. They're not listening. They're just listening to when they want to listen, those kinds of things. So speech delay is something that quickly often improves with speech therapy, but it again becomes a hidden disability for kids with this at a very early age. Absence of interest in other kids. Usually kids with fetal alcohol spectrum disorder want to play with other kids. They often are challenged with that because they get frustrated. But kids with autism tend to not mind being on their own. They prefer it. Kids with FASD want to be with kids, but they get frustrated because they can't, and they feel, what's the matter with me, from a very early age. And then the interactive play we talked about, but hyperactivity and lack of ability to engage in sustained play is one of the common things that is a big challenge, especially when you start pre-K and kindergarten, where a kid can't sit still, or they're in daycare and the daycare says we can't take care of him. All right, let's move on to the next slide, please.
A brain-based disorder with behavioral manifestations. A diagram of the brain. Frontal lobes, impulses and judgment, controls executive function. Hypothalamus, appetite, emotions, temperature, and pain sensation. Amygdala, emotions. Cerebellum, coordination and movement. Basal ganglia, spatial memory, switching gears, working toward goals, predicting behavioral outcomes, and the perception of time. Hippocampus, memory, learning, emotion. Corpus callosum, passes information from the left brain open brace rules, logic close brace to the right brain open brace impulse, feelings close brace and vice versa. Source, Dr. Sarah Matson, University of San Diego.
All right, so this slide is highlighting that this is a static encephalopathy. This is a brain-based disorder that manifests with developmental behavioral challenges, primarily behavioral challenges that all too often are reduced to psychiatric illnesses. So when I'm working with psychiatric fellows, child psychiatric fellows, I basically tell them to take the DSM-5 and throw it in the river, because we need to focus on neurodevelopmental challenges first that often manifest with psychiatric challenges like ADHD. Many kids with autism are also diagnosed with ADHD. We might try medications and sometimes they help. But this is a brain-based disorder, and these are important parts to begin to look for, because otherwise you're gonna totally miss why the kid is having the challenges in school. So we talked about the frontal lobe, impulse control, judgment, executive function, the little man who sits at the front of your brain and tells you what to do next, plans ahead, looking down the road, what's coming down the road. hypothalamus that governs emotions, appetite, regulation that ties in with the limbic system, that is the amygdala, and the emotional regulation center we're going to talk about when we talk about traumatic experiences. And then the corpus callosum I mentioned earlier, it transfers information across the hemispheres and basically helps us integrate thought. The hippocampus involved in memory. Many kids with FASD learn it one day, forget it the next. Very frustrating for parents, teachers, but even more for kids. Spatial memory and visual spatial awareness with the cerebellum and basal ganglia. And perception of time is a big one. Challenge is just getting to a place on time. Next slide.
Developmental challenges in children with an FASD.
All right, so we're going to rush through this because I want to get through some of the other parts because we've got 20 minutes left. Age 4 to 12, already we're seeing this, what I mentioned earlier, difficulties with receptive language, auditory processing, hearing it and getting it. So one of the things I ask parents is, how many times do you ask him to do something before he gets it? Oh my God, you got to be kidding me. It's almost always the case with kids with FASDs. Difficulties with conversation. If you're not taking in well, you're just going to be because you want to be liked and you want to be part of the group, but you have no idea what's going on. So then you might start talking about something totally tangential that's not even what the group's talking about. And quickly the other kids are going to be like, yeah, whatever, and they're going to move on. So this leads to the difficulties in peer interactions. Even simple things like 80% of our conversation, of our social interactions, are nonverbal cues. There have been studies looking at how kids with FASDs have difficulties interpreting nonverbal cues, in addition to the auditory processing we talked about. And that frustration that spills over with social interactions comes out in emotional behavioral dysregulation, often as early aggressive behavior, these temper tantrums, these outbursts, having inappropriate interpersonal boundaries, touching people inappropriately, and getting into other person's personal space, being overly friendly to strangers, very common. And then the hyperactive, poor attention, disorganized, almost all the kids have these symptoms, and almost all the kids, people start talking about ADHD really by age 2 to 3. It's pretty remarkable. Impulsivity, lack of awareness of danger, jumping off of places, breaking your arms, really this kind of reckless lack of awareness of danger. And as we move forward, lack of awareness of consequences that leads to a lot of challenges in adolescence and adulthood. Learning challenges, I mentioned, learns it and then forgets it. Difficulty with daily tasks of living. So this is something we're going to get into later on, called adaptive function. This is the kid who's 10 years old, but you got to take care of them like they're 4 years old. You know, you should be able to get up and get dressed and brush your teeth because we got to get to school. You should be able to do this. You're 10 years old. That's the point. Confabulation, I put this down instead of lying. It's making up stories, and often outlandish stories that clearly are not true. You can prove that they're not true, but the kids still insist that they're true. Aggressive behavior we talked about because of this frustration and emotional behavioral dysregulation. High risk for school suspension as early as first grade, kindergarten, school suspension or expulsion. I have kids kicked out of school in kindergarten, kids that have to repeat school, not because of their intelligence, because of their behavior. And then the sleep difficulties we talked about. Next slide.
Adaptive function and intellectual disability equivalence. A line graph. Chronological age on the horizontal axis and developmental age on the vertical axis. Line for individuals with FASD is lower than the line for typical developmental trajectory. Source, Waite and Burt, 2023.
So this is the adaptive function I talked about, and you can see the typical trajectory. Adaptive function is what your mom used to call common sense. That's things that we pick up from being alive in the world. So as you move forward, you kind of get to know how to manage interpersonal relationships. You learn what's polite, what's not polite, how to read people, how to count money, how to pay for things, how to get from one place to another on time. All those things that we kind of pick up by being alive in the world. Those are the areas that it's often not measured by schools. And one of the most common impairments that we see in kids with FASD. So a lot of times we'll talk about an 18-year-old kid who seems like they're 7 or 8 because they need that kind of support. They even seem like that when you're talking with them. So this gap, as you see, gets wider and wider as kids move forward. So one thing about FASD, it gets worse with time. So this idea that we're going to give interventions, we're going to lift them up, God bless. If that works, I'm very happy with that. But we also need to be realistic that this very well might get better in some pockets of areas, but in other areas, this might be a persistent area that people, especially in schools, don't see and that present as behavioral challenges. Next slide.
Developmental age and FASD. A chart of skills and developmental age equivalent. Actual age is 18 years. Physical maturity is 18 years. Reading ability is 16 years. Social skills is 7 years. Living skills is 11 years. Source, adapted from research findings of Stryesk, Claren, et al. Diane Malbon, 1994.
So this is a good example of this. Here we have an 18-year-old kid who speaks like he's 20, but a lot of this is pseudo language. It sounds better than it actually his ability to use language to communicate in conversation. But look at comprehension, 6 years, that's a first grader. Money time concept, 8 years, that's a third grader. Emotional maturity, 6 years. Social skills, 7 years. So you have a kid who's 18 on the outside, speaks pretty good, but look at it where he's functioning at like a third grade level, an 8-year level. And so when you do testing for adaptive function, it's really common to see these things. I do tests for kids who are 16 years old, and in their adaptive function for coping skills, it's less than 2 years. So it's like 16 going on 2, right? Next slide.
Development of emotional/behavioral regulation. Markers from birth to age 3 years. Attention regulation. Physiological regulation. Emotional regulation. Behavioral regulation. Executive regulation. Source, Waite and Burt, 2023.
So this is the developmental behavioral regulation. I'm not going to spend a lot of time on this, the kind of trajectory that we see that develops with time. And this is the area that really is persistently challenging for parents trying to help their kid regulate their emotions, and most importantly, tell the teachers why this is going on, or telling other people why their child is having difficulties. Just like parents that have kids with autism try to explain to people on the street why their kid's doing what they're doing, while everyone's looking at them like, what kind of parent are you? Next slide.
FASD and the effects of adversity on the brain. Infancy and early childhood are critical periods for attachment, trust, self-esteem, conscience, empathy, problem-solving, focused learning, and impulse control. Early childhood trauma and adversity, especially if frequent and unremitting and not tempered by care from a responsive, attuned, nurturing caregiver, affect the neurobiology of the developing brain. Toxic stress alters genetic expression and alters the architecture of the brain. Open brace epigenetic close brace. Those areas of the brain most affected open brace: the amygdala, hippocampus, and right prefrontal cortex. Close brace are those involved in stress response, emotional regulation, attention, cognition, executive function, and memory. These are the same regions that are affected by prenatal alcohol exposure.
All right, so on top of all this, so this is what we come into the world with. Now you begin looking at what happens after birth. And this is where we get into the whole concept of attachment, trust, all the things that happen with that give and take of parenting. That's the wonderful part of parenting, but often gets disrupted if you have difficulties with substances or alcohol. It takes away everything you love in life, and you cannot be the parent you want to be because of your substance and alcohol use problem. And eventually it often takes your kids away, and often leads to a graveyard or homelessness. It's a bad, bad disease that we as doctors are not good at caring for. Having said that, this spills out, and because if you don't have a good attachment to your child, not because you're not a good parent with good wishes, but because of your problems, Oftentimes, this sets you up for not being able to keep your child protected from other people, or also from getting frustrated and leading to physical abuse. So this begins the cascade of why these are often intertwined. Neglect, people falling asleep during the day because they passed out, and meanwhile the kid's in the crib, right? So this part, you begin to talk about trauma and adversity and how this overlaps with FASD to really give a much more challenging developmental picture. And we know that trauma itself affects the developing brain. This has been called toxic stress in a lot of the pediatric literature. Psychiatrists and psychologists, it tends to be focused on the traumatic experience of post-traumatic stress disorder, which taught us about this. But this affects specific areas of the brain that are involved in emotional regulation, primarily the fight or flight response, and the part of our bodies that help us regulate our emotion. So part of treatment for PTSD is beginning to give tools to help us regulate our emotions and begin to be able to function in a non-stressful environment. So let's go to the next slide that shows this kind of in a graphic way.
Brain changes in FASD and PTSD occur in areas of the brain that control emotional/behavioral regulation. A diagram of the brain with areas shaded in yellow representing FASD and areas shaded in red representing PTSD. These areas overlap and include parts of the corpus callosum, frontal cortex, midbrain, hypothalamus, basal ganglia, cerebellum, limbic system/hippocampus and amygdala.
This is a slide I put together that kind of highlights some of the areas of the brain. The yellow are those parts of the brain affected by FASD, by prenatal alcohol exposure that we talked about earlier. The red part are parts that are affected by post-traumatic stress disorder. And we talk about affected by this, we talk about brain cell atrophy, brain damage from chronic stress. All right. So we could look at parts of the brain like the amygdala, the hippocampus that are actually smaller in people with chronic PTSD. We know there's underlying immune issues that, by the way, also happen in FASD. So there's a huge overlap here that we're going to learn more about in the next 10 years. Next slide.
Developmental challenges of adolescents within FASD.
So this is what I call a constellation of adversity. The kinds of things that kids in foster care come into our care with. And so when you began playing out from a 13 to 21 year period, you can begin to see the challenges that we're up against. I talked about the increasing gap between chronological age and developmental age, 18 going on 10, right? The tasks of daily living, adaptive function, difficulties with receptive language, reading nonverbal cues, engaging in back and forth conversation, difficulty making and keeping friends. This is a really traumatic part for kids with FASDs. They really begin wondering, what's the matter with me? Why don't people like me? You know, and because they want to have friends, but they just can't do it. They make them and then they get upset at their friends, and say something and they lose their friends. Poor interpersonal boundaries. So there can be issues with inappropriate sexual behavior, but also as we move forward, gullibility and lack of awareness of others' intentions that might lead you to be sexually victimized. And also not only victimized sexually, but also as you get older, gullibility, being involved in doing criminal activity because someone says, let's go do this. Next slide. So moving forward, we talked about confabulation. Oh, Johnny gave this to me, that's why I have it. You know, making up stories about, well, you know, my credit card's missing and there's $1,000 on the credit card. Oh, I don't know what must have happened. I saw somebody outside though, maybe they took it. Taking possessions of others, also called stealing, that's very common. High risk for school failure and dropout. If you were going to your job every day and your boss was saying, why can't you do this? every day. This is what kids with FASDs go through. Their heads are banged against the desk every day. So eventually you would quit your job. They stop going to school. That puts them at risk for hanging out with deviant peers, hanging out in the streets, and again, getting influenced by peers to do and get involved in the criminal justice system, again, because of poor impulse control. Major challenges in child-parent relationships. And this is something, you know, as a person who works with families, I can't begin to tell you how agonizing this is for me. And often makes me feel very inadequate. But sometimes just being there with families, I think, helps. But a lot of aggression against parents, a lot of destructive behaviors of objects in the home, running away, really challenging. Emotional behavioral dysregulation, often diagnosed as bipolar disorder. And remembering that this runs in families, they are increased risk of alcohol and substance use. Next slide.
A history of prenatal alcohol exposure, basis of the diagnosis of an FASD. A pyramid diagram. At the base, prenatal alcohol exposure. Then, neurodevelopmental challenges. Then diagnosis and intervention.
So the base of this, because fetal alcohol syndrome, I can make a diagnosis because it's found on exam. But for all other FASDs, the 9 out of 10 kids we talked about that don't have the facial features and growth impairments, we got to get a history of prenatal alcohol exposure. So every kid entering foster care, every kid entering the juvenile justice system, every kid entering the criminal justice system as adults should be screened for prenatal alcohol exposure. Next slide. This is how I do it.
Screening for prenatal alcohol exposure.
I like to start with how far into your pregnancy were you when you discovered you were pregnant. This sets a timeline for me. Most women discover their pregnancy between, 4 to 8 weeks, 1 to 2 months. So I like to get that as a timeline. So let's just say I found out I was pregnant at 8 weeks. Did you have any medical problems during your pregnancy? Were you prescribed any medications during your pregnancy? So right now I'm asking standard questions, right? But then I can go back and say, before you knew you were pregnant, how much alcohol did you drink? Beer, wine, liquor. And then, sometimes they'll say, oh, no, I don't drink. But other times they'll say, oh, I drank a little, just on weekends or social drinks. And then you can begin to get down into the nitty gritty of how much alcohol specifics. After you found out you're pregnant, how much alcohol did you drink? If you begin asking these questions, you'll be surprised how many times you get a positive history of prenatal alcohol exposure. Doesn't mean you're going to diagnose a kid with FASD just because you get that. But if they start having the things we just talked about, you got to start wondering about that. What about other substances such as weed, cocaine, other drugs before you're pregnant and after you found out you're pregnant? Next slide.
Barriers to FASD diagnosis. Lack of systematic screening for prenatal alcohol exposure by obstetricians, pediatricians, psychiatrists, psychologists, and social workers. The relatively hidden nature of the disorder, with a large portion of those with FASD presenting with no overt outward physical signs. Open brace, about 90% close brace. Lack of system-level resources for intervention services specific to a FASD diagnosis. Source: Grubb et al., 2021.
So there's barriers. I mean, it's almost like I could say, what isn't a barrier to FASD diagnosis? I mentioned how no one's screening for prenatal alcohol exposure, but all the people listed up there, all the professionals, including all people in child welfare, should be screening for this systematically, right? There's lack of awareness of FASD prevalence, how common it is, 2 to 5% in the general population, even higher in foster care, up to 20% in foster care at least, right? People feel uncomfortable asking the questions I just talked about. So I tried to give you a platform on how to go about asking these questions because it is a little uncomfortable at the beginning. They're going to feel as comfortable answering as you are asking. Underreporting of alcohol use, especially in foster care. If I'm a mom and my kid's in foster care, why would I tell you I used alcohol, right? I'd be an idiot, right? Because I want to get my kid back. Right? And so this ties in with stigma, fear of repercussions, including if you just say it to your pediatrician, Are they going to call CPS, child protection, on you? Lack of biological markers. We have some markers in meconium, the first bowel movement that babies make, that we can test for, but right now that's only research-based. There's lots of challenges associated with that. Relatively hidden nature of the disorder, that most kids do not have facial features. And then a thing I often hear from pediatricians, what would you do once you make a diagnosis? What's that going to do? Well, that's a good question, but that doesn't mean we shouldn't begin diagnosing kids so we can build these services, because the treatment for a kid with FASD is different from a treatment for a kid with autism or isolated ADHD. Next slide. Right, so this is the gray area, the biggest challenge, and probably many questions here about what do I do if I don't get a history of prenatal alcohol exposure, but I know he was exposed to cocaine or opioids? Good question. Right? What I like to do is say this is a neurodevelopmental disorder associated with prenatal cocaine, alcohol exposure unknown, or alcohol exposure unconfirmed, right? Because it puts it on the game board. So we begin to talk about the things that we just talked about as challenges that we want to do moving forward. Often findings that we see on psychological evaluation can also distinguish autism from FASD. Kids with FASD tend to have high verbal scores compared to low nonverbal scores, whereas in autism, they have very low verbal scores compared to high nonverbal scores. And often, as I mentioned, there's normal to cognitive ability, oftentimes borderline to normal, so they don't meet criteria for intellectual disability, but you look at their adaptive function and it's very, very low. That's where we have to work. We have to start where the kid is. Next slide.
FASD interventions. A circular diagram with 3 concentric circles. In the center, learner can do unaided. In the next circle, one of proximal development open brace learner can do with guidance close brace. In the outer circle, learner cannot do.
So the middle circle is where the kid is. That's what they can do without help. Next circle out, what they can do with help. The circle on the farthest zone out is the things that even with help they can't do. Too many times we're expecting the child to work at that outer circle where we need to start in the middle circle. And we're expecting them, and if they can't do that, we're saying they're not trying hard enough, or there's something wrong with the parents. We need to give more meds, whatever it is. But meds notoriously are not always that helpful for kids with FASDs. We have to shape the environment. So this is looking at the environment, and this is the main reason for giving a diagnosis. The only reason for a diagnosis is to do something about it, right? So we talked all this time about what a diagnosis looks like. Now let's briefly talk about educating parents and foster parents. This is not that they won't do it, it's they can't do it. Looking at this as a disability, right? Beginning to talk about interventions to help and reframe behaviors using antecedent strategies to help support families. Beginning to get services in place like early intervention, special education, vocational education, early vocational education. Kids can do things. They just might not be able to do what we're expecting them to do. We need to get the cookie cutter and shape it to the child instead of the cookie cutter. Realistic expectations, start where the kid's at, put support in place before the child fails. So this is against the school system that tries to put kids into the least restrictive environment. Many times I'm having to argue for the services before the kid fails. And then coordinating the services, which is its own nightmare. Next slide.
Building community-based FASD-specific intervention services. Start with that works. 5 points. First, diagnostic, medical, and mental health services. Neuropsychiatric testing. Psychiatric treatment. Second, special education services. Least restrictive environment. PT, OT, speech/language. Vocational. Third, individual skills training. Focus on strengths. Social/friendship skills. Team groups, mentors. Personal safety and adaptive skills. Executive function skills. Time and money management. Dialectic and cognitive behavior therapy. 4. Support and advocacy networks. Education. Emotional support for birth parents and caregivers. Advocacy within educational, Legal, juvenile justice, and social services. 5. Early intervention. PT, OT, speech/language, adaptive. Social communication. Sensory processing. Source, Waite and Burt, 2023.
This is my dream of what we would have, where I diagnose a child with an FASD and all these services would fall into place, right? This is something we have to frame at a local level, oftentimes one child at a time. It's really difficult work, and every parent of a kid with an FASD will tell you how difficult it is, but they also will tell you ways that you can do it. So that network of parent communication and support, it cannot be overestimated. Next slide.
Risks for adolescents with FASD. The average age children with FASD begin having trouble with the law is 12.8 years. 50% have a history with confinement in a jail, prison, residential drug treatment facility, or psychiatric hospital. Among 287 youth seen over a year's time in a Canadian juvenile court, 23.3% had an FASD.
So when we talk about FASD, where are we going? Well, this is our current treatment for kids with an FASD. We lock them up, and especially males. I get worried about females with an FASD getting sexually victimized. They often run away. They're easily gullible and talked into how wonderful they are, how pretty they are, let me buy you this stuff. And pretty soon they're being sexually victimized and trafficked. So that's my big worry for women, as well as with early pregnancy. I try to get all my female adolescents birth control early on if there's any sign that they might be sexually active. But 60% of kids have history of trouble with the law. It's often stupid things, right? I had a kid who was 12 who watched How to Steal, and he went down to Walmart and stole Pokemon cards, right? So they steal things that are not age appropriate. One guy I just wrote a legal thing on, they broke in and he was on the so-called lookout, and he's like 32, and he took cooking materials because he likes to cook. You know, everyone else took TVs and things of value. So really, really common. No one's getting screened in juvenile justice. We need to screen these kids. Next slide.
What's in a diagnosis? The primary reason for diagnosis is intervention. Diagnosis allows education of caregivers about the disabilities associated with the neurodevelopmental disorder open brace, such as FASD close brace, and anticipatory guidance for risks and current or future need for interventions. Diagnosis allows individuals with FASD to better understand their strengths and weaknesses open brace, blind spots close brace. Ideally, diagnosis allows access to disability services.
So diagnosis is for intervention. It allows us to begin to talk about this with parents and advocate for kids. It ideally allows us to get disability services at the state level, just like autism and intellectual disability can. And I begin to talk about the kids themselves, that you have a blind spot. Just like I have difficulty walking and I use a wooden thing to help me walk, a wooden walking stick, you have a difficulties knowing when things are not safe, right? Stuff like that. Next slide.
Adversity and resilience. Adversity and traumatic experiences are not destiny. Resilience is the developmental process by which an individual can use internal and external resources to negotiate and adapt to current challenges while developing skills to aid future challenges. While recognizing risk factors for adverse outcomes, a new awareness has focused on resilience and protective influences that support development. This trend toward focusing on strengths and improved quality of life has become an important new direction in supporting individuals with FASD. Sources: Forkey, et al., 2021, Van Meter and Chichetti, 2020, Olson and Sparrow, 2021.
So adversity is not destiny. FASD is not destiny. All right, we can shape this with time. Next slide.
Resilience. Resilience is the developmental process by which an individual can use internal and external resources to negotiate and adapt to current challenges while developing skills to aid future challenges. Resilience implies the presence of adaptive capacities to negotiate life challenges effectively. The greatest association with improvement in resilience is having more than one strong network open brace biological family, peers, Foster care close brace. Young adults can demonstrate resilience in one area of their lives even as they struggle in others. Those caring for children and adults living with an FASD can never overestimate the effect of the day-to-day interactions they share with children in foster care.
And this is where we can begin to talk about resilience, building adaptive capacities. But unfortunately for FASD, this means building the environment. And many times this falls on parents, and they can't do it alone. We need to build this in the community. Next slide. I want to just close with this one part.
What promotes resilience? Maston coined the term ordinary magic to describe resilience founded upon ordinary rather than extraordinary processes to shift to a more positive outlook that supports child development among children experiencing adversity. These include an attachment to a competent caregiver, cognitive development with the opportunity for continued growth, mastery of age-salient development tasks, self-control or self-regulation, the belief that life has meaning, hope for the future, a sense of self-efficacy, and a network of supportive relationships. Streisguth identified several factors associated with improved outcomes in adulthood for children with FASD. These include early diagnosis open brace. Though only 11% of individuals with FASD were diagnosed by age 6 close brace, eligibility for state developmental disability services, living in a stable home with nurturing parents with a minimum of changes in the household, and protection from witnessing violence or suffering abuse. The importance of a stable home environment makes facilitating early permanency planning with families of origin or other caregivers one of the most critical interventions for children in foster care. Each disruption of foster home placement is associated with significantly more difficult child behavioral problems and poorer adaptive function. Sources: Maston, 2001, Forkey et al., 2021, Streisguth, et al., 2004, Streisguth, et al., 1996. Spoor et al., 2007, Bada et al., 2008.
So there's this term that Maston has coined called ordinary magic, how parents can bring resilience and just this ordinary parenting. I think that everybody who adopts a kid, who fosters a kid, thinks that they can turn this kid's life around. Well, a lot of times we can. Next slide.
The limitations of environmental interventions. Despite the hope that attachment and placement stability will support child development, the developmental course of children with FASD often eludes the ordinary magic described by Maston. Families with strong parent-child attachments often struggle as the developmental challenges of children with FASD and to become more difficult as age-related expectations increase beyond their abilities. Awareness of these challenges allows parents and professionals to anticipate risks that lie ahead and use anticipatory guidance to mitigate these challenges. Source: Maston, 2001, Waite and Burt, 2023.
But many times kids with FASD, and I'm talking from experience, it eludes the ordinary magic, because I see wonderful parents just heartbroken because of where their kid ends up. And there's no healing for that kind of difficulty. But I think as providers, we can be there with them, and we can try to get mitigation if they end up in court, which is a lot of what I end up doing, but mostly trying to bend the trajectory, which is the next slide.
Bending the trajectory. Photo of a person behind bars. Then, photo of a person working on a bicycle in a shop.
So these people can do things. These kids can do things. As adults, we can get them jobs. They might need help getting to work on time, right? They might need someone to check in with them. They might need apps on their phones to help them survive. But they can do things. They're good people who have issues and challenges in their development, often manifested as behavior as well. Thank you for your time and attending.